In the previous section, we saw a lot on iron metabolism and iron indices, but in this particular section, we are going to concentrate on the microcytic anemias. You have 4 microcytic anemias to be basic. You have an iron deficiency anemia, you have thalassemia, and you're going to have sideroblastic anemia, and you're going to have something called anemia of chronic disease. So these are the 4 classic microcytic anemias. Of that, I already told you iron deficiency anemia and anemia of chronic disease. In early stages, they may also present like a normocytic anemia. They can also present like a normocytic anemia, which is the fact which we discussed already in early stages only. But these are classical for iron deficiency anemia. But in this particular section, we are going to discuss all the microcytic anemias except thalassemia, because thalassemia, yes, it does deserve to be a separate video because you have so much things on thalassemia to understand. So that's the reason. So, but apart from that, let us kick it on. So the first thing is the iron deficiency anemia I'm going to discuss. It's a very classic iron deficiency anemia. So the moment you talk about the iron deficiency anemia, you have to know the etiology, because we have discussed a lot on the iron, the sources and all these things already, so it makes the job simpler now. So we are going to just see the etiology of iron deficiency anemia. So as far as the etiology is concerned, I'm going to discuss under 3 different headings. One is the chronic bleeding. The second one is reduced supply. And the third one I can call it as increased demand. Increased demand. So whenever you talk about a chronic bleeding, so one of the main reasons for the chronic bleeding is usually the gastrointestinal or genitourinary bleeding, which can be due to a malignancy, which is extremely important, especially the colon cancer. The malignancy part, maybe it could be menstrual losses, excessive menstrual losses. If the menstrual losses, even it could be normal menstrual losses, need not be excessive, but if it's not replaced adequately, in a long run, you might result in iron deficiency anemia. Or it could be due to parasites like hookworm infestation, especially in countries like India, or you might get with NSAIDs. Obviously, like NSAIDs can cause peptic ulcer bleeding. So NSAIDs, or alternatively you can cause any peptic ulcer disease. So these are the things that you have to know in chronic bleeding. Apart from that, when you have a reduced supply, means typically we are dealing with something called a malnutrition. So malnutrition, because of that, if you're having iron deficiency, typically goes towards a celiac disease in exam. So celiac disease, if they ask you the most common extraintestinal manifestation, answer is iron deficiency anemia. Very, very common. So many patients even come with isolated iron deficiency as a first finding, but rare. But they can come with an isolated iron deficiency as a first and earliest finding, even before diarrhea or other malabsorptive symptoms, possible in a celiac disease. That's why this is really, really important to understand. At the same time, it could be due to Crohn's, or it could be due to increased gastric pH. Where you get increased gastric pH, typically in atrophic gastritis, or you don't have the stomach at all for hydrochloric acid secretion, and which can facilitate iron absorption. Like if you're having a total gastrectomy especially, or subtotal gastrectomy, or in many bariatric surgeries. These are the reasons for generally going for malabsorption. Iron is not absorbed properly, because of that you get a lot of issues. Increased demand can happen in children, adolescents. We already discussed all these things, because the growth spurt, and patients who are pregnant, definitely high extraction by the fetus, definitely increased demand. Patients who are on ESAs, again ESA treatment will accelerate the erythropoiesis. To accelerate erythropoiesis, you need sufficient amount of iron to support the erythropoiesis. That's the reason ESA treatment also results in increased demand, and many of the times patients may go for overt iron deficiency anemia. So, but one thing we not discussed in the etiology, that is a very rare cause, that is called a IRIDA. We actually discussed a lot about IRIDA in the hepcidin section in the last video itself. This is called iron refractory iron deficiency anemia, that is due to matriptase 2 deficiency. We have discussed in the last video itself, so I'm not going to discuss right now. It's a genetic association. Apart from that, if somebody asks you the clinical features of iron deficiency anemia, I'm going to tell like general signs and symptoms of anemia. So in the form of, you might have lethargy, you might feel fatigue, you might feel, like an external sign, maybe a pale patient, you might see a bald tongue, or you might see a even a cardiac failure symptoms like tachycardia, you might have pedal edema, you might have basal crepitations because of cardiac failure. All these things might happen, hyperdynamic circulation, all these things are quite common in iron deficiency anemia, in any anemia for that matter. So general signs and symptoms of anemia you might see. Apart from that, you might see this kind of brittle nails, or you can see koilonychia, which is always referred to as spoon-shaped nails, and you can see alopecia, hair loss. So usually in exam, this is one of the questions, how you detect koilonychia. The definite koilonychia is determined by something called a bead test. That's what we do. We do something called a bead retention test or bead test. For this koilonychia, since the definition of the koilonychia is spoon-shaped nails, if you keep a small bead, since the nail is like a spoon shape, the bead, what you keep, the small bead-like thing, when you keep it, it will be retained because the nail is spoon shaped now. It will be retained perfectly in the nail. But if you keep it in the normal nail, it will be falling down either side. So this is what we refer to something called a bead retention test. So which I'll show you in some time. So next thing, you can see something called a pica, otherwise called as pacophagia, which means eating like some inorganic substances like sand, chalk piece, and all these things, silicon related things, all these things. That's called pacophagia. And patients may also result in dysphagia. That is due to a lot of reasons you get dysphagia. One of the main reasons is Plummer-Wilson syndrome, which I'll discuss. Then patients may develop something called an angular cheilitis, which is very important. The corners of the mouth may get inflamed. This is what we call as angular cheilitis. Then patients may develop something called an atrophic glossitis. That's why I told you a smooth bald tongue. Smooth bald appearance, that is due to loss of the papilla of the tongue. So that is the reason. And apart from that, you might result in development of something called a Plummer-Vinson syndrome. So if somebody asks you what is the triad of the Plummer-Vinson syndrome, you're going to tell it is due to post-cricoid dysphagia, which in turn is due to something called upper esophageal webbing or post-cricoid webs. Again, it's a post-cricoid web causing post-cricoid dysphagia, or otherwise upper esophageal or post-cricoid webs. And you have something called an iron deficiency anemia, which completes the triad. And one important thing about Plummer-Vinson syndrome is this webs, number one, is pre-malignant. These webs are pre-malignant, which means they can predispose to squamous cell cancer of upper esophagus. Generally, it's very rare to have a cancer in the upper esophagus. This can predispose to squamous cell cancer of the upper esophagus. At the same time, remember, treatment will not regress the webs completely. So treatment with iron may not regress the webs completely. But remember, this dysphagia will respond to treatment. The dysphagia usually responds to treatment with iron supplementation to an extent, which means the mechanism of dysphagia is not only due to the formation of webs, there is something else also that is causing dysphagia, which we don't know. So treatment, dysphagia responds to treatment, but the webs do not completely regress with treatment, and there is also a risk of squamous cell carcinoma developing from these webs in the upper esophagus, which is extremely very, very important. And these webs are easily determined by endoscopy, as well as you can determine easily by your routine barium swallow. It's not that difficult to find out these webs. Generally, if they ask you what is the treatment of these webs, if they are causing significant dysphagia, then treatment of the webs may be with iron supplementation. Obviously, little regression is possible, but not complete regression is usually not possible. Plus or minus, you can do something called endoscopic balloon dilatation. Balloon dilatation. So that is what you're going to do in the endoscopy. These are the treatment options for this Plummer-Vinson syndrome. So next, we are moving on to the investigations of iron deficiency anemia. The investigations you're going to do, like iron deficiency anemia is one thing that is extensively investigated by, in lot of textbooks. You have a lot of findings to deal with. So the most important investigations, first thing, let us see the RBC indices. So what are the RBC indices? Obviously the hemoglobin will be decreased, the hematocrit will be decreased. That is, hematocrit and hemoglobin are decreased. That is because of the reduced number of circulating RBCs. Circulating RBCs will be reduced because I told you, whenever you have a bone, and if I want to draw a bone marrow, so you have this CFUE which has to mature to a reticulocyte. So for maturation into a reticulocyte, you need iron, isn't it? So you need an important substrate called iron to mature into the reticulocyte, and because of that which is released and you get the mature RBC. Suppose if you don't have this iron, the maturation process will also stop, and even though CFU might survive, but the maturation will not happen. Because of that, your reticulocyte count and RBC will decrease, which means iron deficiency anemia is one of the examples of a hyperproliferative anemias. You have to note that. So this is a reduced number of circulating RBCs. Apart from that, the reticulocyte index will be reduced. There's no doubt about that because it's a hyperproliferative anemia. And MCV will be low because of low hemoglobin. Because the low hemoglobin itself causes MCV, isn't it? Because low hemoglobin in the cytosol. Then you have MCHC may be decreased, low cytosolic hemoglobin. That is due to low cytosolic hemoglobin, because the amount of hemoglobin inside an RBC is reducing. That's why the RBC becomes smaller in size and microchromic and hypochromic, microcytic and hypochromic. So MCV reduced, so MCHC will be reduced, which means I'm going to talk it's a hypochromic anemia, and MCH also will be reduced. That's what we call it as hypochromic anemia. So RBCs are typically microcytic and hypochromic. At the same time, your red cell distribution width will be increased. Very, very important finding, because in anemia of chronic disease, your red cell distribution width may be normal. So here it is increased. Very, very important, which means the anisopoikilocytosis will be too much in iron deficiency anemia. The variation, the shape and the size will be too much in iron deficiency anemia. So the next thing, what you see in the peripheral smear after the RBC, in the peripheral smear, you're going to see a microcytic hypochromic RBC. If you tell microcytic means the RBC size should be smaller than that of the nucleus of a small lymphocyte in a peripheral smear, and hypochromic means the central pallor should be occupying more than 1/3 area of the 1/3 of the diameter of the RBC. So which means if normally this is the central pallor, means in iron deficiency anemia this will be the central pallor. So which means it's going to cause more pallor, more area of central pallor than what you see. So this is what you see, the increased central pallor, more than 1/3 of the diameter of the RBC. So that's what you're going to see. At the same time, these are things you're going to see in the peripheral smear. Then what are the iron indices? Iron indices, if you ask me, the serum iron will be low. The serum ferritin will be low because stores will be exhausted completely, and your transferrin saturation will be low because of the low iron in the blood. At the same time, your transferrin receptor will be increased, your TABC will be increased, and your one more important thing is your serum transferrin receptor to the log of ferritin ratio will be more than 2. Very, very important. This is a very important thing as far as the exams is concerned. Apart from that, these are very important facts, because in iron deficiency anemia, what happens is if you take an iron deficiency anemia, so let us assume this is the stores of a normal. So this, if you take this is the normal and this is the stores. Let us assume these are the stores. These are the stores normally, and this is the blood. In the blood you can take, this is the transferrin capacity. Since you take the transferrin capacity, so this tends to be the TABC, that's called total iron binding capacity, because that's the norm, and the amount of iron that is bound here is what we are going to call it as the serum iron. So this is what we are going to call it as something called serum iron, and in transferrin terms this is what we are going to call it as something called a TSAT. The serum iron is the one that you can equate in transferrin terms to something called a transferrin saturation, and the remaining, the total one, is what we call it as this thing, and this is what we are going to call it as unsaturated iron binding capacity, and the entire transferrin part, it is going to reflect as something called a TABC. But this is normal. So let us assume this is normal, and you have some amount of, in the stores you have some stores are there. So I can put here also. So let us put stores as pink maybe. So these are stores. Some stores are there. Maybe not like this. We can put something like this. So the stores are, maybe a little stores is still there in the normal patient. So what happens in your iron deficiency anemia classically? So when you take an iron deficiency anemia, so first thing what happens, the stores will be completely exhausted, which means no stores. In fact, this is the first thing to happen. So which means in a normal person, the stores will be reflected in the form of serum ferritin, but in iron deficiency, the serum ferritin will be completely undetectable, or it will be less than 10 to 20. Very, very low serum ferritin, because the stores will be exhausted completely because they suck everything from the stores till you don't have any iron supply in the form of intake. So what will happen is, since the stores are low, intracellular iron will be low and the cell will start synthesizing excessive transferrin receptor and transferrin. So your amount of transferrin is going to increase. The amount of transferrin is going to increase. The moment your transferrin increases, your soluble transferrin receptor also will increase. Your soluble transferrin receptor also will increase, because I told you the principle in the last thing, the genetics and the iron regulated protein iron response element. Obviously the transferrin receptor synthesis also will increase because there is no iron intracellularly, so they have to trap a lot of iron. For that you need to have a lot of surface receptors of iron, whatever available iron they have to take for the survival. So you need this transferrin receptor and transferrin to be secreted in excess. So which means you can see the TABC over here. The TABC is definitely increased. There is no doubt about that. The total iron binding capacity, that is equivalent to transferrin, isn't it, in indirect terms. Now if you see the amount of iron circulating in the blood, it's going to be very, very low. So if you see the amount of iron that is in the blood, which means the serum iron is going to be terribly low. And if you ask me the transferrin saturation, again it's going to be extremely low. Which means transferrin saturation, I told you the formula is equal to serum iron divided by TABC. Here the serum iron is low and the TABC is very, very high, giving rise to a situation where the TSAT will become very, very low, less than 20, even less than 10% we have seen. But in general, less than 20% TSAT is considered to be very low in real life. So this is what the findings is going to happen: undetectable ferritin, and you have like elevated transferrin receptor, you have very high TABC, and you have very low transferrin saturation and serum iron. So these are the findings that you're going to see in a classic iron deficiency anemia. Apart from that, other findings that you might encounter if you ask me the other findings, what all you might see in iron deficiency anemia: bone marrow staining. Bone marrow iron staining, you can use iron stains. So when you see these stains detect the bone marrow stores, and it will be completely absent. The bone marrow iron stores can be completely lost. You might not have any bone marrow iron stores at all in the first place. That is very, very possible, real-time possibility. You might not have any bone marrow iron stores in the first place. So how you are going to stain the bone marrow? With the help of something called Pearl's Prussian blue stain, which might show entire bone marrow stores will be absent. It will not stain blue at all. Apart from that, to be honest, if they ask you the gold standard investigation for diagnosing iron deficiency, your bone marrow is considered to be the gold standard. But whether it's used or not, if you ask, definitely no, it is not used. So to diagnose iron deficiency, doing a bone marrow is absolutely ridiculous. So we don't do it, but it's the gold standard. This is the way to find out concretely that it's an iron deficiency, but we still don't do it. But other findings, if you ask me what all things can be there, it will be undetectable hepcidin levels will be there, like ferritin. Hepcidin also will be completely undetectable. The reason for why hepcidin is completely undetectable is because this low circulating iron will definitely suppress your hepcidin release. We have seen the mechanism already. That is due to the low circulating iron completely suppressing the hepcidin release. And number 3, you can see the free erythrocyte protoporphyrin will be increased. That is because you have heme and you have globin, you have heme and you have something called a globin to form the hemoglobin. You know very well, to produce heme you need 2 more essential components, that is iron and you need protoporphyrin. Here iron is not available, so heme synthesis cannot happen, but the protoporphyrin synthesis still happens, so which means the free protoporphyrin levels will be high. So that is the reason free erythrocyte protoporphyrin can be increased, but this is not at all a specific finding because it can be seen in anemia of chronic disease and sometimes in sideroblastic anemia also, depending on where the block is. So you cannot really consider this as a very important finding. And additionally, evaluation of iron deficiency anemia is very, very important. The moment you diagnose it's an iron deficiency, you have to find out what is the cause. So it could be menstrual loss, it could be malabsorption, it could be even malignancy sometimes. So my evaluation is very easy. For example, you have to suspect cancer in the first place. For example, if the patient is having upper GI symptoms predominantly. This is simple evaluation which I do, is not given in any textbooks, but still I prefer this way. If the patient is predominantly having UGA symptoms, I prefer doing an endoscopy. Really, UGA scopy. Endoscopy in the sense I'm going to go for upper gastrointestinal scopy. So typically I'm going to suspect like a peptic ulcer disease and all these things, gastritis, GERD, peptic ulcer disease. There may be existent peptic ulcer, atrophic gastritis, a lot of things you can diagnose through this in upper GI endoscopy. Or if the patient is having lower gastrointestinal symptoms, typically like example, they're having a chronic diarrhea, or if the patient is having history of like risk factors for cancer, risk factors for malignancy, in the sense family history of colon cancer, or if the patient is an elderly patient, age more than 50. Now in these conditions I'm going to generally prefer a colonoscopy as a first choice. You can do an endoscopy also, but you can do colonoscopy because this is the first choice in this. Suppose if the patient is completely asymptomatic, so that's the problem here. If the patient is completely asymptomatic, it's very difficult to evaluate, because in asymptomatic iron deficiency, you can think in different ways. For example, the patient is completely, which means asymptomatic in the sense I'm not talking about the symptoms of iron deficiency there are not asymptomatic in the sense there is no localizing symptoms for iron deficiency, which means the patient is not having UGA or LGA, no family history of cancer. You don't get any particular history to suggest some target investigation. In this, investigation depends on your day-to-day basis. For example, if it's a premenopausal woman, typically this is the age group where you're going to, that means women in the reproductive age group. So this is the women group we are going to commonly encounter iron deficiency. So in this condition, I'll be giving a trial of oral iron. So then I'm going to see the response and decide on what could be the reason for iron deficiency. So suppose if it's a postmenopausal woman, or if it's a man, because a male has nothing to do with iron deficiency. Whenever you see an iron deficiency in a male, it's something very significant. So if it's a postmenopausal woman, or if it's a male with iron deficiency, because males have nothing to do with the blood loss, there should be something. They don't menstruate, isn't it? So there is, what is the way for the blood loss? You have to have some ulcer, or you have to have some, something. So in this condition, if it's a postmenopausal woman or if it's a man and they are completely asymptomatic, then your life is going to be very bad. You have to go for endoscopy. You have to do celiac profile, celiac testing like anti-TTG, IgA, all these things has to be done. And you also have to do stool occult blood, or if it is positive, stool occult blood positive, then you can even go for a colonoscopy. So you have to do UGA endoscopy, that means upper GI scopy. All this evaluation has to be done for the patient. Or you can do a stool routine test also, where you can look for the ova cyst also. Maybe it could be parasitic infestation like hookworm causing the iron deficiency. So if the trial of oral iron is not working, so then you can do all this process. If still suppose trial of oral iron is not working, not responding to that, then you can go for all this testing. If then this is also clear, completely normal, then think about probably congenital disorders like IRIDA, that is iron refractory iron deficiency anemia. So this is a very simplified flowchart, but what to do first, what to do next, whether you do endoscopy first in asymptomatic patient or whether you do celiac testing in asymptomatic patient, it all depends on the place of origin, geography, or what is the celiac disease incidence in your area, and suspicion. You have any clinical features of celiac disease, all these things depends on a lot of things. So it is not like first, second, all these things. This is the general profile we do for a patient who's asymptomatic and don't have any problem at all. So this is how you generally evaluate a patient with iron deficiency anemia. So the evaluation part is also extremely important in a patient with an iron deficiency anemia. So with this we can see the profile of iron deficiency, you can clearly see this is what we call it as something called an angular cheilitis. And this is the post-cricoid web, esophageal web of a Plummer-Vinson syndrome. And here what you see is the koilonychia, the spoon-shaped nails, koilonychia. And you can see this is what we called as a bead test, where the bead perfectly holds in position because of the spooning of the nails. In a normal nail, it doesn't happen. So here is a peripheral smear picture which showing a lot of pallor. This is definitely more than 1/3 of the RBC diameter. It's a huge pallor in the center of the RBC. This is a microcytic as well as hypochromic RBC. And you can see this is a normal bone marrow iron store by Pearl's Persian blue. You can see a lot of iron stores, like stains blue in a lot of areas. So this is a normal iron store in a normal patient. But here if you see, this is a patient with an iron deficiency anemia where you don't see any stores at all. There is absolutely no storage iron in this patient. So it's again a very important thing to understand. And this is the final thing. What I'm trying to show is this is the response to iron. So this image shows response to iron. So which means the moment you start replacing this iron, if there is a good response, what you're going to see is you're going to see a dimorphic population, which means a lot of things like lot of RBCs you are showing, these are well hemoglobin. This hemoglobin content is high in this RBCs, which are new RBCs that are synthesized. And you can see a population of hypochromic RBCs which are having a lot of pallor in the center. These are nothing but the old RBCs. So you will see a dimorphic picture in the peripheral smear when the patient is receiving iron supplements once they have been diagnosed with an iron deficiency anemia. If there is a good response in the early stage, this is what the picture you are going to see. You are going to see something called a dimorphic picture, which is very, very classical. And obviously, like the moment you start the iron supplements, your reticulocyte count will definitely increase. So these are the iron deficiency, some of the pictures that are important for exams. So if they ask you the stages for iron deficiency, classically there are 4 stages for iron deficiency. Knowing all the 4 stages is not important for your exams and not important for your practice as well. So generally you can split into 2. One is called a latent iron deficiency. Latent iron deficiency, which means this patient will have iron deficiency but without any clinical anemia or laboratory anemia. You don't have any anemia. The only evidence of this iron deficiency will be on the bone marrow iron stores will be lost. Bone marrow iron stores will be lost, and the second evidence will be low serum ferritin. That's why I told you one of the earliest marker for iron deficiency is decline in the serum ferritin or undetectable ferritin. Apart from that, second you will get your classic iron deficiency anemia. So after this there are mild, moderate, severe cases and all. So in classic iron deficiency anemia, you will not only have iron deficiency, you will also have associated anemia, both clinically as well as laboratory, which means clinically also patient will be pale. At the same time, lot of laboratory indices also will be altered, like MCV, MCH, your iron indices, other iron indices apart from ferritin, all these things will start getting altered. So this is what is going to happen in a classic iron deficiency anemia, which happens a little bit later. So the next thing, if you ask about the treatment of iron deficiency, so first thing very important is the treatment of the cause. Address the cause, very, very important, because if it's a peptic ulcer bleeding, no matter how much you replace, you're not going to get any improvement as long as they keep bleeding through the ulcer. So if it's a hookworm infestation, they're not going to respond. If it's a celiac disease, they're not going to respond unless and until you're giving the gluten-free diet. If it's a cancer, unless until you remove the tumor, they're not going to respond. Even if there is a response in this case, it's going to be only transient in nature. It's not going to be for a long time. So first treat the cause, which is ideally very, very important. The next thing what you have to do is oral iron. Oral iron is suitable in a lot of cases, especially nutritional deficiency. I really don't like the term nutritional deficiency. If the replacement is not proper in times of excess demand, that's what we indirectly confuse ourselves as nutritional deficiency. But to be honest, let us stick on to the textbooks which tell nutritional deficiency. If you have a nutritional deficiency, typically you are going to replace with oral iron, which is the choice for nutritional deficiency. In this condition, how long you're going to use the oral iron? So you're going to use at least 6 weeks is needed to correct the anemia. So you need approximately 6 weeks to correct anemia, but you need approximately 6 months to replenish the stores. To replete the stores, you have to give the iron supplements for 6 full months. This is very, very important point, because just you correct the anemia, hemoglobin is improved, you can't stop the oral iron. You have to replenish the stores completely. So the iron supplements, even after the correction of anemia, if they ask you how long you will continue, you have to continue for 6 months. At the end of 6 months only, you might take a call to stop. Apart from that, you don't stop in between, even if the anemia or hemoglobin is corrected. So at the same time, there is a lot of people do ask me, taking oral iron, will it cause stool occult blood to be positive? Will the stool occult blood will be positive just because you take the oral iron? Because there is something called a Kuyak test, so which tests for the stool occult blood, so which is actually based on the principle of detection of heme in the blood. Heme in the stools. If it's positive, it's going to tell you as a positive blood in the stool. So is oral iron going to cause stool Kuyak positive? Answer is no. A lot of modern textbooks tell no. The current stool occult blood testing what we are going to use is not going to cause any problem with the stool occult blood test. Taking oral iron will not cause any stool occult blood positivity, to be honest. And what are the side effects? Side effects, most common, as many of the girls over here would have experienced, is the gastrointestinal symptoms. That's going to be the most common. Intolerance, GI intolerance is going to be the most common. It could be anything. It could range from nausea, vomiting, abdominal pain, which might look like ulcer related pain, or it might look like cramps. It might even cause a lower abdominal pain, upper abdominal pain. It might cause constipation. It might cause diarrhea, anything for that matter. So second symptom is metallic taste. Almost 10 to 20% of the people discontinue the oral iron because of the GI symptoms. It's such a very important symptom, gastrointestinal symptoms. At the same time, if you are developing GI intolerance, suppose if the patient is developing GI intolerance, what you should do? One option is to switch to IV iron. That is different. But other oral, if the patient is reluctant to start with IV iron, in those cases you can give actually lower doses of iron. Lower dose of iron. For example, if you're using 2 times a day tablet, then you can make it once, or if you're using 3 times a day, you can make it once a day. For the time being, lower doses you can use, or you can change to a iron tablet with low iron content, low elemental iron, low iron content. So this also might help, because the iron is the one that's causing the GI symptoms, because it's an oxidizing agent. It's going to bombard the intestine with a lot of free radicals, and that's the reason why you get the GI symptoms. If you reduce the dose, or if you reduce the iron content in the tablet, definitely you're going to reduce the symptoms as well. You can try, otherwise it's better to move on to the IV iron. It's very important. And remember, one more thing, don't use sustained release preparations. Sustained release preparations actually increase the intolerance rather than decrease the intolerance, which is a proven fact. So what are the formulations available? What are the ways you can replace this iron through tablets? You have 3 formulations basically. One is called ferrous gluconate, and second one you have something called a ferrous sulfate, which is the standard of care in many of the government hospitals even now. And third one you have something called a ferrous fumarate. So you have 3 different formulations. You have ferrous fumarate. So each of these things they will ask you the elemental iron content. It's a very important point actually, amount of elemental iron present in all these kind of tablets, because you have to know before replacing, isn't it? So it's a very basic thing. So ferrous gluconate approximately contains 12% of the iron content, which means, for example, if you take 300 milligram, it approximately contains 300 milligram of ferrous gluconate. It's going to contain 37 milligram of elemental iron approximately. Similarly, ferrous sulfate contains approximately 20% of elemental iron, which means if you are taking a 300 milligram tablet, which is going to contain approximately 67 milligram of elemental iron, 20%. So then if you are using ferrous fumarate, it contains 33% of elemental iron, which means if you are taking a 300 milligram tablet, it's going to contain approximately 33 into 3, 99, but around approximately 107 milligram of elemental iron, which means the highest iron content is with the ferrous fumarate. The highest iron delivery also is going to happen with the ferrous fumarate. As such, it's the one, ferrous fumarate is the one, because of very high iron content, it's the one that's going to have the maximum gastrointestinal intolerance and side effects as well. The next thing, what you want to know is the dose of these drugs. If you want to know the dose of these drugs, you can tell the ferrous gluconate. Generally, we don't give unless and until the patients who are not tolerating the other forms of oral iron. Apart from that, we don't give generally ferrous gluconate. We don't prefer. Only in intolerant, oral iron intolerant patients who they're not willing for IV iron also, in those patients you can try gluconate as an alternate basis. Iron sulfate, typically we give 1 tablet TDS. 1 tablet TDS is the classical dose of iron sulfate, ferrous sulfate. So, this you can give 1 tablet BD. Actually, your compliance will be very high because of the 2 times a day tablet. Apart from that, there is no other advantage of ferrous fumarate tablets. So these are the things you have to know about them. So what will be the response? So these are things you know, and what is the response to iron therapy? Once you have started the treatment, what should be the response? There are 2 types of response. One is called the clinical response, and second is the laboratory response or hematological response. Hematological response, the clinical response always is early, then followed by the laboratory response. So the first and the early is the clinical response. Among the clinical response, if they ask you what is the first to respond, it is the subjective symptoms. The subjective symptoms are the ones that first improve after replacing with iron. After replacing with any form of iron, we're talking about oral iron here, but after replacing any form of iron, the subjective symptoms are the ones that are going to respond first. In that also, what is the first subjective symptom to respond is the pica. Pica is the earliest to respond. It responds within 12 to 24 hours. Pica is the first to respond. Then next to respond is fatigue and irritability. It responds within 24 hours. Fatigue and irritability, and your epithelial signs and symptoms is little bit delayed. Your epithelial signs and symptoms. Epithelial signs and symptoms like your koilonychia, angular cheilitis, glossitis, all these things will take approximately 1 to 2 weeks. But fatigue and irritability within 24 hours, pica within 12 to 24 hours, it will respond. So then other findings, for example, you have a koilonychia. This is a special thing. Koilonychia is not an epithelial finding, it's a nail finding. Koilonychia typically takes approximately 6 months to resolve. So it's something clinical but still very late, not that early. If they ask you the laboratory improvement, laboratory parameters that improve, if they ask you the first thing that happens laboratory wise, that is called bone marrow erythroid hyperplasia. So erythroid hyperplasia, this is the fastest thing that happens. It happens within less than 2 days, but nobody is going to see the bone marrow to look for the improvement after giving iron replacement, which is typically ridiculous again. So increase in the reticulocyte hemoglobin, again this is not something we're going to find out. This happens within 3 to 4 days approximately. The next thing, you have reticulocytosis in the peripheral smear. Reticulocytosis in the peripheral smear, this is very important. Actually, you can look out in the normal peripheral blood vessel. That's why this is important. It happens approximately around 1 week. Whenever I write this kind of simple, don't get confused, it's approximately 1 week it takes. Then later on followed by increased RBC count, your increased hemoglobin, and your red cell distribution width is something the last to recover in the peripheral smear, and finally followed by your replenishment of bone marrow iron stores. That is the last to happen. It typically happens around 6 months of time. So by the end of the treatment. So your increased hemoglobin, you have a cutoff. The target for increased hemoglobin after oral iron is very important. So if it's the target, so you should see something called rate of rise should be approximately 2 grams per deciliter every 3 weeks. Every 3 weeks your rate of rise should be approximately 2 grams per deciliter. So that is the standard rate of rise. If you don't have this particular rate of rise, if you don't have this 2 gram per deciliter rise every 3 weeks, you can tell the response is poor. There could be a lot of reasons why the response is poor, but if you ask me what is the reason for poor response to treatment, the first always comes non-compliance, always. So majority of patients do not take the tablets properly. That is the reason why the improvement may not be adequate. So non-compliance is very important. Second thing, if the patient is having continuing bleeding, continuing hemorrhage continues, obviously underlying cause is not treated, or it could be a wrong diagnosis, which means just because it's a microcytic hypochromic anemia you're taking as iron deficiency, it could be a thalassemia. Possible. So do not think about that. Or it could be other microcytic anemias or other microcytic hypochromic anemias, like even a sideroblastic anemia or anemia of chronic disease. You are doing a wrong diagnosis. That's why it's not improving. Next, it could be a mixed deficiency, like probably patient might have combined B12 and folate deficiency as well, or if the patient is having other causes for loss like malignancy, anemia of chronic disease and all these things, or if the patient is having associated malabsorption like celiac disease, then you might be having atrophic gastritis, Helicobacter pylori infection. All these things may cause malabsorption because of various reasons. Because of that, you might result in a poor response. Or if you are using a slow release preparation, usually slow release preparations are actually associated with a slow rise generally compared to the standard release preparations. You have to remember that talking about the slow release preparations definitely is very important to understand. It takes time to rise. It takes a little bit of time. So these are the conditions where you're going to have a poor response to oral iron. Then comes the hero. It's the IV iron. So then comes the hero, who is the IV iron. So the moment you think about the IV iron, so first thing you have to know about the indications, then we can go up the preparations. The first indication, straightforward, intolerance to oral iron. Intolerance to oral iron. Next thing, for example, if the patient is on CKD on hemodialysis, or if the patient is having congestive cardiac failure, or if the patient is having cancer, malignancy, in these conditions it's better to replace with IV iron. Especially simple example, if the patient is having CKD on hemodialysis, whenever there is a patient is having CKD on hemodialysis, means you're going to have a high hepcidin levels. Definitely when you have a high hepcidin, it's going to block the iron absorption from the GIT. So once it blocks the iron absorption from the GIT, how you think the oral tablets will work? It won't work. Oral tablets is not going to work at all in the first place. So that is the reason why you prefer IV iron in these patients. In terminally ill patients, there's no indication for oral iron. So before giving ESA treatment, before giving erythroid stimulating agents like erythropoietin analogs, before ESA treatment, obviously we prefer IV iron because of the faster rise. Because ESA is something faster. You need a faster rise in the iron stores. So you can't do a oral iron for 6 months and then give ESA. The patient might die before that. So it's not suitable again. And for example, if the patient is having excessive and persistent GI losses, excessive and persistent gastrointestinal losses. So typically in a severe malabsorption, you have to replace faster, IV iron. Suppose if the patient prefers quick treatment, definitely, this is the real-time possibility because patients don't want to take for 6 months or 10 months treatment. So in this condition, you can go for IV iron. So number 6, in pregnancy, if they ask you what are the indications for IV iron, you can tell if the patient is near term, or if the patient is more than 20 weeks. If the patient is having near term plus iron deficiency anemia, this is indication number 1. Or if the patient is having more than 20 weeks of gestation plus hemoglobin in the range of 7 to 9 grams per deciliter, this is the second indication. Either the patient is near term having iron deficiency anemia, or if the patient is having a gestation period of more than 20 weeks plus hemoglobin in the range of 7 to 9 grams per deciliter. These are the indications for giving IV iron in pregnancy. These are the Government of India recommendations for that matters. So you have to know that. So then what are the preparations you have? So the preparations, what you are going to have for replacing this iron is number 1, you have something called a ferric gluconate. Let us compare and contrast. You have something called a ferric gluconate once again. Ferric gluconate. Second one, you have something called iron sucrose. Number 3, you have something called ferrumoxytol. Number 4, you have something called a low molecular weight dextran. Remember, currently what we have is only low molecular weight dextran. We do not have high molecular weight dextran right now. It is banned from the market. You don't have high molecular weight dextran. Then you have something called a FCM, that is called a ferric carboxymaltose. FCM. Then you have something called iron isomaltosidase. If you ask there could be a question. This is the one that is having the highest, molecular weight. To be honest, among all the preparations, this isomaltosidase is the one that has the highest molecular weight among all the compounds. Among all the compounds, the highest molecular weight is for ferrumoxytol. Ferrumoxytol is the one that is going to have the highest molecular weight among all the compounds, all the preparations. You're going to have the highest molecular weight with ferrum oxytol. Then what are the concentration of iron in each of this, and whether test dose is required or not, and finally what will be the dose of this agent. So that's what you're going to see. If you ask the concentration, it's 12.5 milligram per ml. Iron sucrose is 20 milligram per ml, and ferrum oxytol is 30 milligram per ml, and low molecular dextran is 50 milligram per ml, and FCM is 50 milligram per ml, and isomaltodextrin is 100 milligram per ml. So I have arranged the doses, arrange the compounds in such a way that the doses are in this particular order. It's increasing as you move from the top to bottom. So if you ask me, the highest dose is for isomaltodextrin. This is the one that is going to have highest concentration of iron in the standard dose, 100 milligram per ml. The next is with FCM and low molecular dextran. After that is ferrum oxytol, then is sucrose. The least is going to be with your iron gluconate concentration. This is the least, the compound with least iron concentration per ml is your ferric gluconate compound. So test dose, if you ask me, typically not required for gluconate, not required for sucrose, not required for ferrum oxytol, not required for FCM, not required for isomaltodextrin, but you need a test dose for dextran. Dextran based compounds definitely need a test dose. There is no doubt about that. Usually how much test dose we will give is some 25 milligram of iron initially we give as infusion and see for the reactions, and if they don't develop any reactions, then you can go for further infusions. This is the test dose. And what about iron gluconate? How much you can replace? You can replace ferric gluconate 125 to 185, 187.5 milligram, and you can give multiple doses. Into multiple doses you can replace. So similarly, iron sucrose you can give 200 to 300 milligram, multiple doses, which means you cannot replace heavy doses at one point in these two compounds. And next you have ferrum oxytol, where you can replace 510 milligram into 2 doses. So which means you can give 2 doses of 510 milligram, second dose 8 days apart. So 8 or more days apart, you can give 2 doses of 510 milligram. This is the standard dose of ferrum oxytol. And you have something called your iron dextran, where you can give 100 milligram into multiple doses, or alternatively you can give 1000 milligram single dose. 1000 milligram single dose. This is also possible. Then for FCM, which is my personal favorite, you can give like 750 milligram. This is a standard dose. 2 doses of 750 milligram you can give 1 week apart, 7 days apart, at least minimum 7 days. You can give after 10 to 15 days also, but 7 days is the minimum. So that is the idea. 7 days apart, 2 doses of 750 milligram. Isomaltodextrin you can give 500 milligram into 3 doses, and all 3 doses you can give within a span of 7 days. Within 7 days you can give all 3 doses over a 7 days period. Rather than writing 7 days, you can write over 7 days mark. You can give all the 3 500 milligram doses, or even you can prefer a single dose of 20 milligram per kilogram into single dose. This is a full dose you can replace. So single dose you can give. So these are the treatment that is important, because I believe in exams they're not going to ask these many doses, but still I urge you to know the FCM dose alone at least, because this might be the question exam, because FCM has become the norm in many centers right now. So probably in clinical centers we use a lot of FCM right now. So that's the reason probably this is very important. And please do remember, high molecular weight dextran is no longer available. And if you ask me, every single compound is given in IV preparation only. Every single compound is given in IV preparation only. There is no IM preparation. The only thing that has both IV as well as IM preparation is your low molecular weight dextran. This is the only thing that has IM as well as IV preparation. At the same time, one more important thing to understand is about this ferrum oxytol. The interesting thing about this ferrum oxytol is it might result in some bright signals in MRI. It might produce bright signals in MRI up to 3 months. Up to 3 months after giving ferrum oxytol, you might see a lot of bright signals in the body. Small spotty bright signals is possible in MRI. and this should be notified to the radiologist. Radiologist will ask the history obviously, but at the same time this should definitely be notified to the radiologist, because sometimes it might lead to some error prone diagnosis also, because this might create bright signals in the MRI for the next 3 months in the patient. So among this, if they ask you out of all these things what as a preservative, only one thing as a preservative, that is ferric gluconate is the only thing that has a preservative in the form of something called a benzyl alcohol. This is the only thing that has a preservative. Apart from that, none of the other things has a preservative, no preservative. That is, benzyl alcohol is there in ferric gluconate. So these are the things that are important to understand about the IV ion replacements. If they ask you about the side effects of IV ion, so side effects, you can get early side effects as well as late side effects. Early side effects is typically flushing, possible, metallic taste, possible. Allergic reaction, anaphylaxis, the current preparations is generally very rare. You don't develop an allergy or anaphylactic reactions with the current generation of IV replacements. IV replacements are very safe. Remember, IV replacements, all the preparations of iron which is used IV are safe in pregnancy. All the iron preparations which we use, IV iron preparations which we use are safe in children. All the IV iron preparations which we use currently are safe in CKD patients also. So there is no inhibition whatsoever. Late complications, they can cause myalgia, arthralgia, a long-standing fever, plus or minus. There are certain case reports telling lymphadenopathy due to IV iron. So this is also possible. And how will you calculate? What is the amount of dose that is needed for IV ion? There are a lot of doses and modified doses are there in the current right now what we follow. But if they ask you how will you calculate a dose of IV ion, so we have a popular formula called Ganzoni formula, which is currently outdated, this Ganzoni formula. But what is the Ganzoni formula that you are going to use in these patients is that the formula tells you the amount of IV iron dose that you need is 2.4 multiplied by 15 minus hemoglobin multiplied by actual body weight in kilogram plus iron needed for stores. Iron needed for stores. Remember, this iron needed for stores is highly variable. You might need some 500 to 1000 milligram. You might need something variable from 500 to 1000 milligram. It depends on the lot of factors, but generally on the safer side you can replace 500, or if you are planning to have CKD patients who need continuing erythropoiesis going on, you might even need 1000 milligram. It again depends on your personal expertise. The stores needed is somewhere around 500 to 1000 milligram, but Ganzoni formula is not that accurate, so we have replaced with a lot of newer formulas. The newer formulas, if you ask me the more accurate formulas, it is 2.145 multiplied by 14 minus hemoglobin multiplied by actual body weight, not the ideal body weight, actual body weight plus iron needed for stores. Iron needed for stores in milligram. So these are the newer formulas. The second newer formula which you can use is 0.442 multiplied by desired hemoglobin, what you need, minus actual hemoglobin multiplied by lean body weight, that is ideal body weight in kilogram. This plus you have 0.26 multiplied by lean body weight. So these are the newer and more accurate formulas, but in exams I will suggest you to use this formula. So easily you can use this formula. You can, in exam, whenever they ask you to calculate the amount of iron needed, you can simply put 2.2 multiplied by 14 minus hemoglobin multiplied body weight plus iron for stores. You can use this formula for exam. If somebody asks you, you can use this formula for calculation based purpose. You can use this formula typically. So this is very simplified formula. I've just made 2.14 and approximate 2.2. So you can use this formula in the exam. So this is a very simple and elegant formula. So if at all they ask a question based on how much IV iron you need, you can use this. Not an issue. So suppose if there is an ongoing blood loss, this is used typically for surgery. If there is an ongoing blood loss, or if there is ongoing or the blood loss that has happened already, in those conditions, if you know the amount of blood, then you can replace that amount of iron only. So amount of blood lost, if you know in ml multiplied by the hematocrit, will give you the amount of iron needed as well. So if you know exactly how much the amount of blood that is lost during surgery or during trauma, but most of the times it's not possible. But if you know, then you can use this formula also to replace the patient with IV iron. That is also feasible. So will you do blood transfusion BT? Is there any indication of BT? So let us see the indications for blood transfusion in iron deficiency anemia, or in any anemia for that matters, not only for iron deficiency. This is a common indication. So for example, if a hemoglobin, number one indication is hemoglobin less than 8, plus if the patient is having a cardiovascular disease, which means, for example, patient is in a failure, cardiac failure. So patient is in a cardiac failure, definite indication for replacement, no doubt about that. Or second thing, hemoglobin less than 8, plus patient is having an acute blood loss, especially in the setting of a surgery or a trauma, acute blood loss. So less than 8 usually, except in pregnant or except in your like children in the age group of 6 months to 5 years, where the severe anemia deficiency is less than 7. In all the other areas, severe anemia deficiency is less than 8. So that's why we can even write, replace and modify it as a severe anemia also. Plus CVDs or severe anemia plus acute blood loss, you can write in that way also. Number 3, you can write all stable patients, any patient with a hemoglobin of less than 7, which means you can take it as any patient with a HB less than 7, it's an indication for blood transfusion. Or you can use it with symptomatic patients with hemoglobin of 7 to 9 grams per deciliter. Again, this becomes an indication for blood transfusion. And number 5, in pregnancy, whether it will replace or not, yes, in pregnancy you can still do replace. In pregnancy, indications for replacement is hemoglobin less than 5 grams per deciliter, regardless of the gestation age. Here the gestation age does not matter at all. If it's less than 5, straight away go for blood transfusion in pregnancy. If it's in the range of 5 to 7, so HB in the range of 5 to 7, plus if the patient is near term, or if the patient is in labor, or if the patient already is in labor, so in these settings definitely you have to give blood transfusion only. Remember, if the patient is in 7 to 9 range plus near term, you ideally go for iron infusions, IV iron infusions, which becomes indication for IV iron. But if the patient is having a HB of 5 to 7 and near term, or if the patient is in active labor, then you can go for blood transfusion. So these are the indications for blood transfusion in iron deficiency anemia. But in general, these indications can be used for like blood transfusion in any kind of patients, not only in iron deficiency, you can use for any kind of patients as well. So that is one big important thing. So next thing, before going to the second part of the video, I can even tell you some of the 2 important types of microcytic hyperchromic anemia, which is generally very rare. The first thing I discussed about IRIDA, which already discussed in the hepcidin section in the iron metabolism, which is due to MAT tryptase 2 deficiency. MAT tryptase 2 deficiency, here we'll have refractory iron deficiency anemia, but they will not take oral iron, but they cannot improve their hemoglobin with iron content. So the treatment of choice will be IV iron only. Only IV iron will work here, because the iron absorption will be completely like absent in these patients because of extremely high hepcidin level, hepcidin expression. But the 2 other things that you have to know is, one is called atransferinemia, and second one you have something called a DMT1 deficiency anemia. The dynamics between these 2 are very, very different between atransferinemia and DMT1. It's not like what you imagine, to be honest. There are a lot of things that are going on inside which we have no idea about. Even though DMT deficiency, you think about certain logic, but those logics may not be applicable in real time, because we still don't know about exactly what are the metabolisms and mechanisms that are happening within the enterocyte and within the cell. So that is the reason why some findings in DMT1 anemia might confuse you. You might be thinking why this is happening, why that is happening, because it's not correlating with your routine picture. So in these conditions, it's better to just know them rather than just analyzing them. The most important thing is, first is atransferinemia. This is something easier to understand. Whenever you have atransferinemia, remember, both these are autosomal recessive in inheritance. Number 1. So in atransferinemia, what you will see is, typically you will see a microcytic and hypochromic anemia. There is no doubt about that. And your serum iron will be low because there is no transferrin If you don't have transferrin, you can't have serum iron. It will be extremely low and negligible serum iron, and your TIBC will be completely decreased because you don't have iron at all. I mean transferrin at all. So transferrin is the one that gives rise to TIBC. So TIBC will be completely decreased, or your serum transferrin receptor will be absent. You don't have any transferrin receptor at all. No, if you don't have the transferrin receptor, this is the major pathophysiology in this particular patient. How can you expect a soluble transferrin receptor to be present? It will be absent or decreased too much. And your serum iron, ferritin, serum ferritin may be increased because reticular endothelial system has to push iron outside, and once they push iron outside through the DMT, they have to be carried by the transferrin. If they cannot be carried by the transferrin, that pushing is a waste. If you don't have the vehicle to carry outside, there's no point in pushing the iron outside through DMT1, the reticular endothelial system. So the stores will definitely increase. That's the reason why your ferritin is increased. Your free erythrocyte protoporphyrin will be increased because you can't use the iron, isn't it? So if there's no transferrin, iron cannot be transferred to the RBCs. It's like an iron deficiency to the RBC. So your free erythrocyte protoporphyrin will be increased. These are some of the things. Then you come to the DMT1 deficiency anemia, which is more mind-boggling because we don't know really what's happening, even though it's autosomal recessive disorder. And the mutations, if they ask you, it is due to something called SCL11A2 mutations. Then the reason for what are the findings? You're going to again result in microcytic and hyperchromic MCHC anemia, MCHC type anemia, and you're going to have your MCV to be very low, and for that matter here also the MCV will be very low. I'm not going to differentiate. So MCV will be very low, and you're going to have a increased serum iron with increased serum ferritin, and this is something we don't know. Really, we don't know why. So increased serum iron with increased serum ferritin, and then you have your transferrin saturation that's to be increased, and that is still due to increased serum iron. Obviously your TSAT will be increased, and your soluble transferrin receptor also will be increased. That is due to intracellular deficiency, or STFR will be increased, and serum transferrin also will be slightly increased, and FEP also will be increased. Because the problem is, the main thing what they tell is DMT1 is not working in the intracellular zone. That's the main issue with this particular thing. So since the erythrocytes can't use the iron properly, so the serum free erythrocyte protoporphyrin levels may be increased. So these are the two other conditions where you have to know. One is the DMT1 deficiency anemia, and second is the A transferrinemia, which are the two important types of anemia that might be asked in the exams, but these are very rare cases. You might not be even seeing these cases in your entire lifetime, but still sometimes the questions may come in the exams in this particular disorders. And with this, I think we can cut off this and we can move on to the next section, where we'll be discussing on the other types of microcytic anemias. Like your thalassemia needs a separate discussion. So in the next we'll be discussing more on your sideroblastic anemia, or maybe about anemia of chronic disease and all these things. So let's go to the next one.